Hi, all. We'll be giving everyone a few more minutes to join us, and then we will get started. Thank you again for joining us today for the second webinar in our critical care webinar series. Today, we're excited to talk about setting up a critical care unit, considerations for a low resource perspective. We are waiting on a few more people to join, but I think we'll kick off in the interest of time. So just wanted to start off with a few housekeeping items before I turn it over to Dr. Sweetbert to get us through some of the objectives and then move through the presentation. Like mentioned in the chat, if you have any questions during the webinar, please use the Q&A function. We will have a Q&A session at the end of the webinar to answer all of your questions, either in voice or in text. And we will be dropping some information in the chat box during the presentation itself. This webinar will be recorded, so if you've registered, which you all have, you'll receive a copy of the recording after the webinar via email. The webinar will also be available on our website. You'll see the link here on gradienthealth.org. And then finally, if you have any questions or want to share any feedback or have any suggestions for us moving forward with this webinar series, please email us directly at customers@gradienthealth.org. I'll now turn it over to Dr. Sweetbert to get us started with the first few slides of our presentation.
Hi everyone. My name is Ansbeth Sweetbert Ndebea, based in Tanzania, as I was introduced. I hope you can hear me. Confirm, Mariam?
Yes, we can hear you.
Yes. So I will take you through the first part of this webinar. I'm excited to be with you this evening for those who are in Tanzania or East Africa. And so I have nothing to have no conflict of interest to declare. Next, Maria. So these are our objectives. So at the end of this webinar, we will take you through the following objective, where we will discuss some relevant elements of critical care. We'll describe some basic resourcing for setting up the ICU. We'll look at some structure and systems required to set up the ICU. The most important thing, and that's I think the reason why we are doing this is a challenge. What are the challenges we are facing, especially in the low resource setting? What are the reasons why we don't have much ICU, and what should we do to overcome that? So, because at the end of the day, you all want to have some ICU because you all have some critical ill patients. And the last part will be we discuss some practical recommendation to build up the ICU. So this will be our roadmap for today. Next, Maria. Almost if no, I think all of us we are at one point in our life we have encountered the critical ill patient. So basically, the critical care medicine is the essential service for in our daily activities. It either you work in ICU or you work in the ward or you work in the theater. We all at one point we needed these skills. We need the skills and knowledge to manage a critical ill patient. The challenge we had during COVID pandemic unmasked the need for building capacity around the critical care in the healthcare facilities. So starting up the well-functioning intensive care, we know, especially in this side, most all of us, including me, something when I was in the training. So when someone told me about the ICU, the first thing which came in my mind was like the fancy place, fancy equipment, and all of those things. Of course, yes. Setting up the well-functioning intensive care unit require adequate investment, but with what we have, and I think we can even start from where we are and have this setup, and then we can help our patients. But also, of course, there are some investment needed in infrastructure, in a human resource, and you need some equipment, but also you need consumables, or the most important thing, it's the critical care system, the flow of the patient, protocols, and all of those. So in our countries where most of us are coming from, we know we have challenges, and we face many challenges. Most of them being lack of resources. And so that now, but sometimes we have political will, sometimes we even have a will to have an ICU, but we face some investment challenges. And I think that's why we are here in this webinar, so we can discuss together and see if we can come up with a common language for us to help our patient. So we all need the encouragement so that we can mobilize and invest at least locally with available resource, so that we can build capacity and manage and be able to take care of the critical ill patients. Next, Maria. This is the recap from the previous webinar where we discussed the critical care in general, and actually the most important thing where can we manage these patients. So critical care is a service for the patient with potentially recoverable condition who can benefit from more detailed observation and intensive treatment. Then it can safely be provided in general ward or high dependence area. We will see later. So the critical ill patients can be found anywhere. You can meet them in the ward, you can meet them in the emergency, you can meet them in the ICU. So they are found everywhere. So the most important thing is you to be able to pick up and to pick the sign of deterioration or the sign of a critical ill patient. Basically, for today, we are discussing the ICU. So let's forget the area we can meet these people, and let us focus more on the ICU, as this webinar is more looking at ICU and organizing your ICU, building up your ICU. So what is ICU, by the way? The ICU is an organized system of for provisional care of the critical ill patient. So basically, in ICU is where critical ill patient, we expect them to spend more time. That's where they should be managed. Yeah, it's either with, of course, that's where we expect to have intensive and specialized medical and nursing care. That's where we expect people who they are qualified and they have skills to monitor, but also to intervene this in the course of their management, either physiologically or if there's any life-threatening condition for organ failure or any insufficient, so it can be monitored and also corrected accordingly. So we'll go more with ICU today, and that's because we know that that's the area where most of the critical patient they spend time, and they need close observation, but also they need time-to-time interventions. And next, Maria. So we all know that not everyone in the hospital, will come with either severe ill or critical ill or with after condition. Some they come with their mild or moderate illness. The most important thing is to think or who will benefit from ICU. Yeah, and out of your patient you have managed this week, either you have the ICU or you don't have ICU. Who do you think would have managed managed in ICU, and also maybe the outcome could have improved more if they had a chance to be managed in ICU? And I think if you remember from the previous webinar, we discussed about the factor affecting admission in ICU. Maybe to remember some of them, we had anticipated course of life, we have a prognosis of the patient, coexisting disease, severity of the disease, also the diagnosis. So looking at all of these factors, but also what is needed in the ICU. Do we need renal support? Do they need cardiovascular support? Do they need respiratory support? Taking into account, and then you will see, and then you can triage and know who are in need of the ICU. But also in ICU, this is the area where we provided the opportunity for care escalation, because as a care provider, as the healthcare provider, I don't want to be in the situation where at one point I regret that I could have done A, B, C to rescue this patient. So being in the ICU, which means you are monitoring, you are doing tight monitoring for the vitals and interpretation, so that you could pick if anything comes up, so that you can intervene earlier to avoid the failure, to avoid the syndrome of failure to rescue. But also, the care of the critical ill patient will always affect your overall hospital mortality rate. So if you improve your care for critical ill patient, assuming you have a good protocol and everyone is managing according to those protocols, this will always improve your patient outcome. And if you reduce the mortality in ICU, basically even the overall mortality for the hospital, it always go down. So, but at the end of the day, if you are doing a good job and people they are getting well, even the confidence, the community confidence in healthcare system will always people they always trust you, and they can bring their patient. So that's why you needed to have critical care set up so that you can manage your patient well, so that we can attract more patients instead of staying home until the last minute. They can come back early, they can come early, and then they can be managed, because they always get their trust if your mortality is coming down, and also but also if the quality of your care is good. But also delivery for this service must be supported. And as we said before, setting up the ICU needs investment. And when we say in the investment, we mean that capacity building, maybe we are training the healthcare providers, we need to buy equipment. There are so many angles involved. So we need support from the government, but also relevant partners, professional society. I know most of our country, you don't have critical care society, but I know Kenya, they have one. And I think Uganda, they have, and we are coming up with one. So starting with the society, anesthesia society, because they do manage critical care. We can start from our own society and our own body. Then we can build up from there and ask our friend from the other country. So by combining this effort, you always end up with improved care with our patient. Also partner like Guardian, as now we are doing this webinar series, and then maybe later on we'll come up with the clinical ones. So these are the kind of partnership we need to build up so that we can help each other. But also even hospital partnership, because we all have tertiary hospital, have this hospital, so that always you can partner with whoever who think you can help you in training, and also making sure you improve care of your patient. Next. So there are core elements for critical care, especially in ICU. And I will always insist on this. And early recognition, assessment, and decision making for deteriorating patient. This will always improve your custom and your patient. So I always tell my friends every time I go to ICU, or every time I'm teaching, that there always a difference between doing vital sign and the monitoring. When taking vital sign, you can go there even 4 hours, and wherever you can even do an hour or after every 30 minutes. But if you are not interpreting, looking at the direction where your vital sign are going, either down or up, you are almost as being in the other words. So early recognition is the key, but not only recognition, but also making the right decision to help the patient. That's the most important thing, especially in ICU. There are so many tools where you can download and maybe have them in your ICU, where they will always show you the warning sign. But even you can do when assessing your patient, you can pick what are the warning sign, apply you to deterioration, but also when the patient is decompensating, or maybe when they are decompensating and before the worst scenario happens. So all of this can be picked up during the assessment, and also you can do the right decision, making sure they are not decompensating, but also they are not reaching to the situation where you cannot reverse the situation. So identification of the warning sign is also important. Rapid and timely intervention for patient at risk is also a important key in managing patients in ICU, managing the critical patient. And on this one, it is multidisciplinary. So everyone is being trained. We all know most of our ICU, they are open or closed ICU, whereby you need some more hands from outside. So rapid and timely intervention, either from doctor, or either from the primary physician, or from the consultation is also important. Remember, in ICU, it's multidisciplinary. So whoever is needed has to be there on time. But also we always focus on the immediate life-threatening conditions, because we always save people from death first, and then we will manage the other thing. But sometimes you have to deal with the primary cause, because could be the reason why someone is deteriorating. So assessing, experience, engaging people is the most important thing. Yeah. Sorry, technology, I just lost my, okay, so provision for expert assistance, as I said before, ICU management, patient management is the multidisciplinary. So everyone who should be involved, please ask their help. Next, Maria. So this is looking at least resource allocation all the way from level 0, which are the what. Basically, here I will look at more on the every resource in the hospital, starting from an antibiotic all the way to pump, infusion, everything should be allocated accordingly so that they can save patient life and all the patient can be managed well. But I wanted you to show at least the nursing to patient ratio from the ward, which is level 0, all the way to ICU. You can see in the level 0, we can have 1 to 5, but in ICU, we can have 1 to 1 or 1 to 2, depending on the type of ICU and what patient are you managing. I will leave from there. I'll welcome the second presenter.
Thank you very much, Streetbart, for the nice presentation. That was wonderfully done. I'll take it up and we talk about basic requirements for an intensive care unit. As it was said in the introduction and in the definition that an intensive care unit is an organized system. To set up a ICU, it can be achieved everywhere using the local resources, the little resources that we have in our facilities. It's true, we'll realize later on as we discuss that there are some sophisticated type of care that is needed, needing maybe more advanced equipment, but you can still start and set up your ICU with the little available resources. So in most hospitals, this can be achieved by going around. See, in some institutions, you have equipment that has been dispersed all around the hospital. You can go around, you pick left, right, and then you set up. Let it be a 1 bed, 2 bed, but for as long as you have an area where you are able to take a prolonged management for patients who are critically ill, that is already good enough. So what matters is to identify an area and look around the equipment that's available. Let it be good if you are able to purchase, but if you are not with what is available, you can still start and set up your ICU. And the level of care depends on the level of the hospital. We don't expect everyone from all institutions to do all what is done from the highest level in the country to the lowest level of care. You give at the level that you can, and when you realize your limitation, you think of plan B, which could be sending the patient to where a higher level can be given to the patient. So not being able to do what is done in the higher level should not be a restriction for us to set up an area where we can provide critical care. As we said, the requirement differs depending on the level of care. It can be so basic that you just need very little equipment for you to set up your ICU. Or it can be very complex that you might not even be able to utilize those equipment. I always tell my colleagues that there's no point to request for things that we're not able to utilize due to limitation of our knowledge. You request things that you are able to use, equipment that you are able to use, and then it will be useful. Otherwise, it's going to be waste of resources and a white elephant. Next slide, please. What is that basic requirement? To be systematic, we will address it going in the easiest and simplest way of ABC, where A represents the airway equipment. From the airway equipment, it comprises from those basics like the Gardel cannula, the airway, from the nasopharyngeal cannula, all those simple face masks, the non-rebreather face mask, the nasopron, all these should be available because they could be used at any other point when taking care of your critical ill. Going to complex management of airway, endotracheal tubes, tracheostomy tubes. If the skill of people are trained on how to use the laryngoscope, let it be rigid or fibroscopic laryngoscope, whatever available at your institution, let it be ready and let it be allocated to a unit that you call your ICU. On the breathing, there's quite a lot as well that is needed. You look at your skills, at which level you are capable of doing ventilation. You can either do invasive or non-invasive ventilation. Our machines, like for instance, the CCV, the critical care ventilator, is able to provide both the invasive and non-invasive. And for you to talk of invasive, there should be a skill in terms of intubation. And for you to talk of non-invasive, there are some basic requirements on the type of patient that we should put on the non-invasive type of ventilation. So all those are part of the knowledge of the requirement that we'll discuss in the few slides. On the C, when you look at the circulatory support, there comes now all that you can do in terms of supporting hemodynamics of your patient. And that can go together with some of the drugs that are used. Okay, we jump already on D, where you mentioned different type of drugs that are used for the respiratory system, drugs that are used for the cardiovascular system, drugs that are used for sedation, anesthetic or non-anesthetic. All those drugs, you use them based on the knowledge and understanding of the drugs that you have. The drugs are very little in terms of meals, but the effect that they produce, they really require someone to understand why and when to administer them. The environment, the area where you need to set up your unit, it should be easily accessible by all patients coming from different areas of the hospital. And the area should be spaced enough to have good ventilation, and the mobility of the staff should be easy, because there could be some intense activity taking place there. And then if there's no much space, there'll be so much collision among yourselves. In terms of monitoring, as Sweetbird said earlier on, there's a difference between monitoring and taking vitals. In intensive care, you monitor your patients. you use a monitor that can be complex. It can be a single machine that monitors the cardiovascular system, the respiratory system as well. Or if by lack of that, you can use different equipment, but that can lead you to achieving the target that you would like to reach, monitoring your patient. You can use a single pulse oximeter that gives you a saturation and a pulse. And on the other hand, you can use a blood BP machine that can give you enough information on the hemodynamics. And you also, as a personnel working there, you are doing monitoring. It's not the machine that monitors, but it's you working there who's doing the monitoring so that you are able to take action when things are not okay. You might also need some extra equipment depending on how you are capable of acquiring them. Syringe pump, infusion pumps. Your unit can be connected to dialysis so that there it becomes again a bit more complex. Also, this depends on availability of human resource that is capable of doing such specialized care. So the human resource matters, starting from the most people that you might think is really not needed in the ICU must be oriented on what it is about all equipment. By that, I mean the cleaner should know everything that takes place in ICU and understand them to avoid unnecessary confusion like disconnection of equipment during cleaning, to avoid switch off of a machine when they're still being used. So they should be oriented on how to use it. The nurses, they are needed. Let them be trained or specialized or not specialized. They are capable of doing the necessary job that is needed. The doctors, the physiotherapists, the pharmacists, it's a teamwork. There's no hero there. We don't die alone. We don't work alone. We work as a team with all disciplines. As it was said earlier on, it's a multidisciplinary team type of work in ICU. The consumables, that can also be a good limitation in terms of availability, but utilize efficiently what is available at your institution and use it to resolve the problem that the patient is presenting. Clinical pathways and administrative system. As it said, ICU is an organized system. If there's no system, there will be confusion. Don't look at the ICU as a ward. Look at it as a system, as it works from the time the patient enters, being in the ward, and as it's going out. There should be a well-organized system running smoothly so that things are taking place in the manner that care is being delivered the best so that patients get out of there. Next slide, please. So what system requirement do you need for you to set up your ICU? The administrative structure. There should be a leader in the ICU. The leader can be a physician who specializes in intensive care, or someone who's taking up responsibility, who understands the critical care parts of management. There should be a nurse who's leading the team on the nursing part so that there's well-organized care of patients. And you have to be sure that the care that you are giving there, it's being monitored, it's being measured. So you need a quality assurance and improvement. You should be able to know what we are doing. Is it really to the benefit of the patient? Or if we want to improve it, what do we need to put in place? Where do we want to improve? What should we change for us to reach the level where we should be? You cannot attend to a patient if there's no record. This is a very important thing to have in ICU. Whatever is being spoken, whatever is being discussed should be written down for reference, and so that when instructions are given, one should know at this time, this have to be given, because the time matters. There are medications that are due at a certain time. Maybe if they are not given because they were not recorded, there's no reference, no one would know what was discussed, and then that might be at the expense of the patient's life or outcome. We should have a way of working, a reference in terms of diseases, condition. How do we manage it? This can be organized at your local level. This can be organized in the region or in the society. They can come up with protocols to help you, to guide you how to take care of different patient conditions. And to be sure that you don't miss anything when working with patients, you have to have a checklist for every and each procedure that you want to do. Believe you me, if you have a checklist, just like we see checklists being done in the airplane before taking off, just we see checklists being done in the operating rooms, we also need checklists in the ICU so that you make sure that when you start a certain procedure, all that is needed is in place and ready for use. Admission has always been a challenge in different ICUs. But if there's a system that is above all, admission should also be part of that system. We know which patient to go to ICU. A patient who's going to benefit for his presence in ICU. Remember, the number of space is limited. You can only pick the patient who's having a condition that is going to be for benefit the patient. We avoid being sentimental, but we are objective and we use our own judgment to decide which patient to admit to ICU. And this depends on the type of ICU that we have. Like we discussed in the previous webinar, the type of ICU differs and the person to admit might also be of different category. Sometimes we receive patients coming from outside. Sometimes we are the ones sending to a higher level. So all this must be there. And you have to know at what time should I take decision of sending my patient away because I've reached the highest level of the care that we can provide at our institution. So for this one, you have to communicate in advance with the place where you are sending your patient based on the system that is established in the region or in the country where you are operating from, so that when the patient is being transferred, information has been given and the team receiving is ready, waiting for the patient for them to continue with the type of care based on their recommendation. Resource allocation and prioritization is also a big point to discuss, because if you misplace your resources, let it be human, let it be equipment, let it be consumable, then you might not be able to achieve what the unit has been created for. So we have to be sure that things are in place and they are where they're supposed to be for us to achieve a better care. Thank you. Next, please. What challenges can we face when providing critical care services? And this is common for all of us. Limitation in terms of specialized human resources. Limitation in terms of available area for training, or even if those trainings are available, training area, training schools are there, up to what extent do we train our personnel? So that is a big challenge. So lack of infrastructure and equipment. Quite all right, you can have the human resource, but you don't have where to put the equipment that is needed to be utilized in that unit. And that is another big challenge. And then you might now start thinking of building up. That's the next cost. That makes, again, an ICU to be very expensive, because building, it's a different type of building. It must have different associated factors that will make it run effectively. Sometimes you might have staff who are available, but there's no one to give a continuous education. There's no one to give an extra opinion. It's very important when you are doing such specialized care, such trainings, you always have someone who comes just to give a little of comment, a little of orientation. You might realize like you always gain something new when you have somebody who comes from outside, or when you have somebody visiting you, or you have someone who's a bit more knowledgeable than you and then shares a point over a patient or a condition, and that is very important. And you'll find that ICU is not recognized as an essential service, or critical care is not recognized as an essential service, maybe by lack of understanding what it is exactly. But since you are now part of these webinars and you understand what is critical care service and what is the ICU, as you becoming managers, or as you becoming people with strong voice in your institution, we should be there to facilitate the implementation of critical care services in our institution. Because the patient who come, they don't always go as they come in. They have either two options. It's either they deteriorate and they need critical care service, or they get better as they are and then they are discharged. And those who need critical care service, so it's up to the health system, healthcare system, or the organization to recognize the presence of such in our institution and to make sure that they're given the type of care that they deserve. Next, please. After all this discussion that we had, what type of recommendation can we make? First, we think of to consider mobilizing local available resources. Before you think of bringing something from very far, utilize what is available at your institution. And as you are using what is available, then you realize the gaps that you have, and then you think on how you can fill them up. Don't stay still to say, I cannot start this because I don't have ABC. Throw yourself in the water, start with what is there, do the best that you can with the resources that is available, and with time, you will keep on adding up to fill up the gap and improve the type of care that you deliver to your patient. This being a multidisciplinary type of care, incorporate others as well, so that care that is being given, it's a type of general care that look at a patient as a whole. So this can go from having surgeons involved during the care of patients, physician involved during the care of patients, obstetrician, pediatrician. Everyone should be involved in the care of patients for the benefit of patients, so that you make sure that the patient is receiving the best care that he deserves. Thank you, Miriam. The other point that you would like to do as a recommendation, it's easy to have pathways and protocols available in the unit so that when the condition comes, you know how to attend to a patient, you know which way and what type of care should the patient receive. It's true that patient might come with different presentation, but when there's already a background that is being laid down, it can ease your way so that you start your medication, you start your care, and then you can redirect it based on the presentation that patient is having at the time of his illness. A mentorship program should always be part of the system. For the reason that we discussed before, it's always nice when you have someone else coming, discussing with you or seeing what you are doing, especially if you're at a lower level, having visits, let it be physical or even virtual discussion for you to realize your limitation. And you can only find it to be useful when you realize your limitation and you ask for assistance. Sometimes because of shame, we might say, no, why should I accept someone to come to know? It's always important when somebody visits, when somebody discusses with you and make you understand one or two things that you would have known and understand it better. We should encourage our staff to attend training. As you know, it being a specialized type of care, it requires someone who understands and who's really oriented in the management or in the utilization of equipment that's available in there. And we do research so that we get to know and understand what the problem of our institution or our care that we have in there. Let it be even in operational research to try and find what is the limitation, how can you go beyond our limitation and improve in the type of care. As you are starting, you can join. There are some free platforms or network where you can easily join, and then you get oriented. You get to be shown on how you can do one or two things in your unit. And when you need more support because of your limitation, because of financial restriction or human resource restriction, you can involve other stakeholders who will be able either to support you financially or even by sending other experienced or high knowledgeable human resource to come and orient you and show you what's the way forward. Next, please. What will be our take-home message? In 3 points, we can say critical care medicine is an essential service in every clinical setting. As we said, you receive a patient, there are two ways. It's either they get discharged or they deteriorate. And as it was said earlier on, you identify the time when the patient is changing condition and they need another type of care that is very essential for the better outcome for the patient. To have a functional ICU can prevent unnecessary mortalities. It's very unfair to lose a patient whereby then later on you say, I wish we had this patient wasn't going to die. But now this is the time for you to implement such services so that you stop blaming yourself for not having it in your institution. to set up an ICU, you don't need sophisticated equipment or infrastructure. Use the little available infrastructure or equipment, human resource to start up and set your ICU. And with time, you realize that you become bigger. When you realize your gaps, you fill them up, and then that will lead you to be providing now a better type of care to your critical patient. Next, please. Before we call it the end, we would like to share with you the different resources that we used for this webinar. So you can find all the information that we have discussed in the different resources that are shared here. You can use them for free and help you to understand and do better for your patients. From here, I'll hand it over to Miriam to guide us for the question and answer part of the presentation.
Great, thank you, Doctor. I see one question here, so I will open it up and ask them to jump in and ask their questions. Give me 1 second. Okay, we have a question here from the audience. What are the advanced resources for setting up an ICU? I'll turn it over to the doctors to answer our question.
So what was the question again?
Question is, what are the advanced resources for setting up an ICU, or some of the advanced resources?
As we discussed in this webinar, I'll take it up and then Dr. Streetbird can also come in. As we discussed earlier on, we said to set up an ICU, we don't want to focus on the advanced resources. We want more focus about what is available in your institution. Because if you really want to rely on what is advanced, then you might not be in the position of getting them, and then you might not even start up an ICU. When it comes to advanced, it starts from the airway up to all other equipment that you might use for monitoring. But the minimum that is available, this is what is needed for you to implement with your ICU. So there's no recommendation for advanced equipment for you to set up your ICU. So, but would you want to add up on that question?
Yes. Yeah. Thank you for good question. So I think if you go back to the previous webinar where we discussed the types of ICU, the basic ICU, what you can say, we say basic requirement because we think these are the basic equipment and the structure and the functional needed for you to start an ICU, so you can take care of a patient that cut across either it's a maternal case with some advanced critical disease, maybe eclampsia, all of those, or it's laparotomy or it's sepsis. So if you were doing maybe cardiac, the cardiac ICU is different from it's different from the ICU. For example, in Tanzania, the ICU at Jakaya Kikwete will never be the same like the ICU for the district hospital. So depend on the type of care you are giving. That will require some more advanced thing, maybe continuous invasive monitoring. Some ICU they even need the ultrasound 24/7 ICU for scan, fast, and all of those. So as you move up and become a specialized ICU in certain area, that's why you will need more equipment to manage this patient. But for almost all of us, with the patient we are taking care, we just need this, which we have called the matrix basic ones, which I think we have, but we just need to mobilize them and make sure we have the ICU. I think, I hope I've answered your question.
Great, thank you. We have another question. The question is it possible to set up an ICU without an electricity supply?
Thank you. So is it possible to have a car without a fuel? Most of the equipment in ICU, they will need the power. Starting from the, of course, they are vent with the battery, but you cannot rely on the battery 24 hours, 7 days, 5 the whole year. So monitor, they need the power. So I think you need you need electricity. Either from the solar panel or whatever you have, or from the generator. But I think you will need some electricity for you to be able to do most of the things, especially monitoring.
Great, thank you. We have another question from the audience. Can ICU be operated under general doctors like medical officers, experienced nurses, and anesthetists?
Yeah, I'll go from there, then probably add more. So with experience from our areas, there are very few trained intensivists. Yeah, there are countries where they have 2, 3, 4, 5. You can even count them. So basically, most of the area, most of the centers in Africa, they don't have intensivists. So we always, that's why most of our ICU, they are open ICU. So we always depend with the team, which comes with the patient, but also in some ICU, they have nurses who are assigned to the ICU specifically. So most of the ICU, they are being managed by the colleague you have mentioned, medical doctor, anesthetist, because they are the couple for intubating, make sure they can maintain manage the airway and put the patient on the vent. Experienced nurses. Basically, these are the key people we are targeting with these webinars, so that we can empower them. We can remove that fear, that phobia they have to start the ICU, and then they can build from there. So I think with the colleague you have mentioned, they can start with the patient they are managing. With the guide from the IR center, maybe they can have support from specialists, or if they have specialists coming with the patient, they can be communicating with the specialist taking care of the patient. Even if they don't have, they can have some a site which they are higher from where they are. If you are a district hospital, I'm sure they are specialists on the regional hospital, so they can mentor you and make sure you can assess, you can monitor, and you can intervene, and then you can even refer area. One of the important thing in the course of the critical managing critical patient is knowing when to intervene, and the intervention can be when to refer the patient to the IR center. So they can start with the team they have, because I think they are certain kind of intervention they can do, and then they can manage the patient. Maybe Papicho can give experience from Zambia.
Thank you, Sweetbert. As we said earlier on, the challenge that we face in the low resource areas is specialized human resource. So if you want to use that as an excuse, then we will not have ICU set up in all other areas. As you said, the qualified or intensivists around in different countries, you can count them from your fingers. You know even where they are located, and those that might not be available in all areas or in all institutions. So the available doctors who are there, they are also capable of running an ICU and make it be very useful to treat different conditions that they can manage based on their experience and their knowledge. Thank you.
Thank you. And we have time for one more question. And then if your questions were not answered, please feel free to email us at customers@gradienthealth.org and we will follow up. But in the meantime, here's our last question. To the doctors, what is your opinion on the involvement of caretakers in the management of critically ill patients in areas with low human resources?
Madam, can you repeat that again?
I'll repeat the question. It's what is your opinion on the involvement of caretakers in the management of critically ill patients in areas with low human resources?
I was wondering to understand the word caretakers. Does it mean to call in other personnel who are not from the institution to come help? Or if
I think
that
he
is the
means
case,
family.
Yeah, I think in this case, people outside of the institution.
Not the family members. Maybe you can clarify. I think you mean
Mike,
family
if you
members.
Mike, if you can clarify in the chat, we'd be happy to answer your question.
So if it means family members, they should be involved, and basically there should be family conference almost after every ward round in ICU. Family member, they should be given an explanation. They should be told what is the prognosis. They should almost be involved in the management, because that has got, because remember, when someone is in ICU, you're managing the patient, but also managing the family. Because everyone, we can understand how will you feel when you have someone in ICU, your relative. So it's really important for the family to be involved, but also it's also important for the patient. And there are some science centers in Europe where the family, the patient are even given a chance to stay with their patient, to be around with the patient most of the time. So patient family involvement is also important. The question was meant to mean the family members.
Yes, just to clarify,
in
Mike.
another way that I understand that question, when you said when you have low human resource, maybe it's also like to allow family members to be part of the mobilization or moving patient, things like that. Yeah, that could also be another way that it means in his question. I think for such intervention, family members should be kept away. Yeah. In these areas, we only allow people who understand the movement on how you care about this patient, because a non-trained personnel can easily wrongly mobilize the patient and disconnect other tubings that are very capital to the life of the patient. Just to complete on what Sweetbird said. Thank you.
Thank you. So we're coming to the end of the webinar time. I'll turn it over to my colleague Magdalena to just close us out. And then again, if you did not have your question answered, please feel free to reach out to us via email or on our social media platforms, and we'll be happy to connect with our doctors here.
Hello all, my name is Magdalena. I'm the Global Training Manager for Gradient Health Systems. Once again, I would like to really thank you for attending this training. I know you're very busy, and I know we had promised to have more panelists, that is Dr. Ndaba, there's Dr. Lwimba and Dr. Kaino. But as you all know about your profession, is that anytime you can be called out in terms of emergency, and that's what our dear doctors are attending to. But we are very thankful for Dr. Perpetua and Dr. Ndebea for being here and taking you through the training. I hope you had a wonderful time. And we also want to thank you for staying throughout the training, because it's very interesting that the numbers actually didn't quite move. And I know guys were leaving just due to probably the internet issues, which is actually very, very normal and understandable. And we would like you to look out for more trainings on critical care. We'll be doing more webinars. Please feel free to also share some of the things that you would like us to talk about, or things that you see that we need to improve from our end in terms of making these webinars good for you guys. Yeah, so you can still use the same website. Mariam, if you could just share the websites. I think we have them on there. Yeah, think they'll be shared.
And Magdalena will be sharing it. I'll be just sending a follow-up email to all the participants with the information. So we'll share that.
So fantastic. You'll actually get the email address. But mine is to just thank you, and yeah, continue supporting us as you come in to learn more, so that we can make our healthcare systems better. And yeah, so I'm grateful. So thank you very much.
Great. Thank you all for joining us. We'll be following up, like I said, with an email, and please feel free to share your feedback as well. I hope you all have a good day and a good evening.